everybody. My name is Stuart Schlossman. I do have multiple sclerosis. We have 3 speakers here today. We have Lisa Gonzalez-Getz. She's a disability attorney. She's going to be speaking primarily about SSDI. If you have questions about SSI, she can answer those questions for you as well. Lisa's going to speak for about 35 minutes. Then we're going to do a Q&A with Lisa. Following Lisa, Mitzi Williams is going to be here to speak with you. She's going to speak for about 40 minutes. After Mitzi speaks, Dr. Thrower will speak. And he's here nice and early. We did some interviews with him earlier today. So after Dr. Thrower speaks, we're going to do a Q&A for both Dr. Williams and Dr. Thrower. So let's get started. All right. Dr. Williams. Come on up, Dr. Williams. Dr. Williams, she works at the Atlanta MS Center, correct? Or the Multiple Sclerosis Center of Atlanta. She is compassionate about her care of giving and treating and providing educational programs, providing education to all of you. She's very big on clinical research, and she just wants to do for all of you with MS. So with that being said, come on and take that mic and talk to us.
All right, good afternoon, everybody. All right, how's everybody doing? I see a lot of familiar faces, and I see some faces I've not seen before. As Stuart said, I am Dr. Mitzi Williams. I work at the MS Center of Atlanta. I've been here in the city for the past 7 years. Previously, I was in Augusta at the Augusta MS Center, and I basically spend 99 to 100% of my time caring for people with MS, other than caring for my 2 little kids. But I spend most of my time seeing MS, and I do a lot of work with clinical research. One of my interests is MS in diverse populations, so I do a lot of work with MS and ethnic minority populations. So Stuart gave me a very interesting topic, so I'm going to try to put it together as best I can. I had a couple of topics in one, the title of the topic was Fitting the Pieces of the Puzzle Together. So before we get started, I usually like to do a little poll. How many people here actually have MS? Raise your hand. Good. Friends and family members of people with MS, raise your hand. People who came for free lunch, raise your hand. The lunch was actually pretty good. I didn't eat too much, and I was terrified of getting something on my blouse, so I did enjoy a little bit of the lunch. All right, so very good. So let's get started. All right, where am I clicking? Okay, there we go. All right, so let's get started. For those of you who've heard me speak before, I usually like to ask some questions in the beginning to make sure you're awake. So somebody tell me what MS is. What's MS? Yell it out. Pain in the butt. Okay, now you definitely heard me speak before, right? Okay. All right, so pain in the butt. All right, what else besides a pain in the butt? Let's be a little more medical here. Autoimmune condition, absolutely. Central nervous system, which includes the brain, the spinal cord, and the optic nerves. Anything else? Affects the myelin, right? So the coating of the nerves, right? So I've got my cute little picture here of the myelin. So you can see on the bottom half here, do I have a pointer? Yes. All right. So we can see here, this is the myelin, the coating of the nerve, and basically the immune system kind of chews that up, right? And so when the nerves are chewed up, or the coating of the nerves is chewed up, then that's what results in decreased signaling and results in the symptoms that we see, okay? But what else is MS? MS is not just about autoimmune disease, right? It's about people, right? It's about people. It's about families. It's about the way that you react. It's about social issues, including disability and care and taking care of yourself and your family. So there's a lot more to MS than just the disease part. And so certainly at our center, and I know at the Shepherd Center, we focus a lot on caring for the whole person because we know that MS is not just about what disease-modifying therapy you need to take. It is a family disease, and it affects you as well as those that are around you. All right, so who gets MS? Anybody, right? So we used to think MS was primarily a disease. So it still is primarily a disease of people of Northern European descent. But we're finding more and more that risk may be increased in other populations, especially in a place like the United States, which is really a melting pot of different cultures and ethnicities. We're finding that a lot of other people get MS. African Americans get MS. Asian Americans get MS. So we're finding that there may be some differences in the way the disease presents in different populations. And so we're hoping to use some of that information to make sure that we're treating people effectively. All right, symptoms of MS. Call them out if you don't have a mouthful of food. Fatigue, yes. The way you're going to feel after you eat 2 pieces of bread. What else? What'd you say? Dizziness, yes. What else? Cold and heat sensitivity, yes. Nerve pain, absolutely. Neuropathic pain. Anything else? Memory, cognition, right? Somebody was talking about cognition. Anything else? Numbness, tingling, absolutely. Bowel and bladder, your favorite lunch topic, right? Bowel and bladder problems. All right, very good. And so this is an interesting slide that kind of talks about things in different percentages, right? So we can see that here, almost 90% of people with MS experience fatigue, right? It's a very common symptom, right? The next most common one is 76% walking difficulty, 70% numbness and tingling, and then we see pain is not too far behind that, but certainly cognitive dysfunction in about half of folks, depression in about half of folks. And so we have what we call the visible symptoms of MS, which are very easy for people to see and understand, but we also have silent symptoms of MS, things like cognition, things like fatigue, right? I have many of my patients that say, I'm exhausted when I get home from work, and my husband can't understand why I don't want to do laundry, right? And so it's important for patients and their families to be educated about these things so that you don't think that the other person is just being lazy or not listening to you. Although sometimes they are just not listening to you. All right, so course of disease. So I'm going to go through this quickly and kind of get to the meat of what I'd like to talk about. So the reason I put this slide up is because this kind of segues or gives us a lead into what or how your needs change over time, which is one of the topics that Stuart asked me to address. So basically what happens in the beginning is that most people start out with what we call relapsing remitting MS, right? That's where you have a symptom in the red, it gets better. You may have another symptom gets better, but over time, we see that the symptoms may not get completely better, and that's how you develop disability, right? So this red line is disability. We see in the beginning, oftentimes you have very active MRIs. So if you have a relapse, you may go to the doctor, you may have some of those spots lighting up with contrast, but over time, people very commonly say, Dr. Williams, I feel like I'm getting worse, but my MRI looks the same. You keep saying my MRI looks the same, but I feel like I'm getting worse, okay? And that's because sometimes things like atrophy may be worsening over time. And then certainly we can see dysfunction or loss of function in the areas already affected, right? And so an MRI is like a magnifying glass or a mirror. So you have a mirror where you can see a certain level of detail. And then when I go to a nice hotel, I see those mirrors where I can see every pore in my face, right? So the MRIs we have now only have a certain level of detail. And as we develop better and better imaging techniques, then we'll be able to see more and able to correlate the pictures with the disability that we see. All right, so here's the question. Is MS a one-size-fits-all disease? Absolutely. See, you already know. See, I can go sit down and somebody else can give my talk. No. But so it is not a one size fits all. So if everybody went around the room and told their story about how their MS started, how the symptoms progressed, how they changed over time, everybody's story would be different. Sometimes even if they have the exact same symptoms. So MS is very different in each person. And something that I heard somebody say that I no longer give them credit for, I stole it, is that if you've seen one patient with MS, guess what? You've seen one patient with MS, right? And I don't remember who said it, Ben, but I claim it as mine. I don't know. So don't tell anybody I stole that. All right. So it is not a one size fits all disease. So let's talk about therapy, because oftentimes when you go to the doctor and you're talking about your options, knowing your options, communicating with your doctor, one of the primary things that you talk about is therapy. So I like to look at therapy for MS like a cake because I like cake, right? So I look at it as a 4-layer cake. The first layer of the cake is therapy for exacerbation. So that's where you call the doctor and say, hey, Dr. Williams, I can't see out of one eye or my leg is numb. That's usually when we give things like steroids, okay? The goals of those types of medications are to try to speed the body's ability to recover. They do not really affect the underlying process of the immune system attacking you, but they certainly can help you get better faster. The second layer of the cake is disease-modifying therapy. Those are the medications that we give to try to slow down the process of MS and decrease the immune system's attack. And they all work by different ways, and they all have different side effects and different advantages. The third layer of the cake is symptom management. There are some symptoms that we're good at treating. There are some symptoms that we have no treatment for, okay? But it's important, if you're having symptoms, if you're having issues, to talk to your doctor about it to see what the options are, if any, that are available to help with that symptom. And then finally, the fourth layer of my cake, which some people kind of put into the same layer here, but I'd rather have 4 layers of a cake than 3, is rehabilitation. And that's if you need physical therapy or occupational therapy, depending on what your relapse symptoms are or depending on what challenges you're having. Okay, so timeline of treatments. I couldn't find one that went all the way to present day, but this just kind of gives you a snapshot of how treatment has developed for MS over time. And you can see here since 2010, we've had a whole lot of activity going on. But does anybody know when MS was first recognized as a disease? Who's heard me give a lecture before? Or paid attention when they heard me giving a lecture before? When was it first recognized as a disease? 1800s, right? 1868, right? By Dr. Charcot, who discovered, he's the father of neurology. So 1868, when was our first therapy approved? 1993, right? So we had a very long time in the scientific community. Obviously, I was not alive in the 1800s, but we've had a very long time in the scientific community to see how people do without treatment, right? And we know now that we have treatments available that most of the time they do better with treatment, okay? And since 1993, we've had an explosion of treatments with MS. There's one treatment that's not listed here that was approved in 2017, Ocrevus. And then we have new treatments almost every year, right? So it's a very good time in the field of MS because there are more and more people investing in this field and many people that are working to try to find effective treatments. All right, so what are our goals of therapy? So one of the things that's very important to address with your physician and in talking about communicating your needs is what are your goals? Now, when we think about if a medicine's working, many people come in and they say, Dr. Williams, how do I know if my medication is working, right? These are the things that we look at. So these are the things that we look at in research studies, but these are also the things that we look at in real life. So if any of you have ever been to a dinner where people have talked about different medications for MS, we always have slides where we talk about relapses and we show all these nice graphs. And so basically what we want to try to do is prevent relapses. We want to try to prevent new lesions on MRI, and we want to slow progression of disease. So those are the goals that we look at in research when drugs are approved, but that's also what we look at in real life. And I always try to make sure that when we're setting expectations for medications, MS treatment is very different from what we typically think of with other disease states, right? So we think if you have diabetes, you take a medicine, your sugar comes down. If you have a headache, you take a medicine, your headache goes away. With the medications that we use for MS, they don't necessarily make the symptoms that you have go away. What we're trying to do is prevent you from having new symptoms. Now, the interesting thing is that with some of our newer medications, we are looking at measures of improvement to see if there is improvement, but we haven't yet found medications that truly have been shown to improve the symptoms that are already there. Okay, so that's our goal, but generally we're trying to prevent worsening. So if you come back and you say, I feel the same, I feel the same, I feel the same, I'm gonna be like, great. Okay, let's show baby pictures and talk about, what you did last week. Very good. So how about setting priorities, right? Which is also important. So when we're talking about, and I'm focusing right now on disease modifying therapy, when we're talking about priorities, there are a couple things that we have to address. We have to address effectiveness, right? Safety and tolerability, right? But we have to balance all those things out. And each of these goals and how important or high they are on the list is different for different people, right? So certainly we all want drugs that are effective, okay? But safety can often be a big issue, or tolerability, right? It's not good if you can't take or tolerate the drug. You're not going to take it and it's not going to work. And we also want to balance safety and side effects. So we often have to look and see if you have other conditions that may interfere with medications. So it's kind of a balancing act, which is why I have all these 3 things here. But those are things that you sit and you speak with your physician about, and you guys decide kind of how you prioritize those and pick the treatment that's best for you based on that. All right, what about other considerations with disease-modifying therapy? Sometimes there are non-neurologic side effects. So as we're getting more effective therapies, sometimes there are side effects that we previously didn't have to look at, like things that may affect your heart or affect your eyes. And so we have to look and see if you have any conditions that may interact or interfere with that. Also, we talk about sequence of therapies, which is something we certainly in the MS community as physicians talk about. But sometimes if you take one medication first, it may increase your risk for side effects with another medication. So that's something to take into consideration. And then compliance with monitoring. Some of our medications require that you get lab draws every so often, maybe once a month for certain periods of time. So it's important if you're going to start a certain treatment to make sure that you're willing to commit to whatever monitoring is required to make sure that you're safe while taking that treatment. All right, so you are your own best advocate, right? So what can you do, right? Because people often say, well, I have MS. What can I do to improve my situation, or what can I do to help myself? One thing that you're doing is what you're doing today, increasing your knowledge, right? So attending programs, certainly there's a YouTube channel. There are probably many other programs that weren't conducted here that you can look at. Recognizing also that there are good sources of information and not so good sources of information, okay? So it's important to make sure that you're getting good sources of information. So there are society, foundation pages, other pages of the Shepherd Center has a page. We have a page, the MS Center of Atlanta. So making sure that your information is valid, okay? Become a part of a community. So I encourage many of my patients to become a part of the MS community, whatever that looks like for you. For some people who can't get around, it may be a Facebook group. For some people, it's a support group. For some people, they start their own support group. But it's important to have people that understand what you're going through. So community support is important. Certainly your family and friends can understand and they can empathize, but it's not quite the same as somebody who does actually know what you're going through. So find that support, whatever that looks like for you. Understand your medications and your side effects to the best of your ability, right? So making sure that you have a list of your medications with you so that when you go to the doctor, you can communicate those or any changes to them and understand why you're taking what you're taking. And also know the members of your healthcare team and who to call for help. Okay, because oftentimes, you may have a symptom, you don't know who to call. Most people just call us, and then I say, okay, go call your primary care doctor. So that's okay, but it's important to call if you need help. All right, so it takes a village, and I'm not going to go into much detail about this because I know Dr. Thrower is going to talk about your healthcare team. But oftentimes with MS, just like it takes a village to take care of a child, it takes a village sometimes to take care of MS. Depending on what symptoms you have, everybody should have a neurologist. Everybody should have a primary care doctor. Certainly other members of your team may include psychologists if that is needed, social workers, physiatrists, physical therapists. So your team can expand or shrink depending on what issues you're dealing with at whatever point in your MS journey. Okay, so what else can you do? Plan your doctor's visits. Bring a list of questions and concerns, right? Whether it is on a piece of paper. I have some people that are traditional and like pieces of paper. I have some people that like to use your phone. Your smartphones are smart for a reason, right? Type some notes in there. Give yourself a voice memo. I have some people that bring a family member and the husband or the wife is the list, right? They have the list in their head. But it's important to have things that you want to address when you come to see your doctor. Always discuss your medication if it's working for you and what side effects you're having, okay? Always discuss new symptoms or worsening of symptoms that you're having, and then review your MRI results with your physician regularly. MRI monitoring is very important. And when I say regularly, for some people that might be once a year. Many of us do MRIs once a year. Some people do them every 2 years, depending on where you are on your MS journey. But it's important to have those MRIs regularly because MRIs tell us what's going on under the surface. And it's important because it can affect the way we treat your MS if your MRIs are changing, even if you're not changing, or vice versa. So it's important to have those regularly and know those results. And then finally, take notes about the plan, whatever that is. So again, a voice memo on your phone, jotting down notes on a piece of paper in your planner, in your notebook, or writing things down in your smartphone. Okay. Communicating your needs to your healthcare team. It's important to be open and it's important to be honest, right? When you are diagnosed with MS, I feel like I am many of my patients' family member, right? So whoever your neurologist is, it needs to be somebody that you feel comfortable with, that you can talk to. If you're having issues, we cannot help if we don't know that it's an issue. But it's also important to kind of try to prioritize your concerns. So if you have 30 concerns, we may not be able to get through 30, okay, in one office visit. But try to write as many as you can and prioritize the top 2 or 3 that you would definitely need addressed before you leave, and then we can try to address the other ones as we can. And then bring a care partner to your visit. Care partner meaning a spouse, a friend, a child, a sibling. So whoever is with you on a regular basis and involved in your care and involved in helping you. It's important because oftentimes they see things that you don't see, right? So there may be symptoms or issues that you're having that you may have forgotten about, but that also that they can see from the outside, and that can help kind of inform the way that we're treating your MS. All right, so then this is the last part that I'm going to talk about. So how could your needs potentially change over time and how to address those? So sometimes mobility is an issue that changes over time. It's a very common one that we see with MS. So ways that we address that or talking to your doctor about certain things could include physical and occupational therapy if that is needed. Sometimes we have to address if someone needs a walking assist device. Maybe you have more trouble walking and you need a cane or a walker. Sometimes seating clinic if you need a scooter or a wheelchair, and then in some cases home health assistance, depending on where you are in the course of your MS. So sometimes mobility is a big one that changes, and certainly we try to address any changes or worsening in that arena as they come up. What about cognition? This is another common thing that can change over time. It is a very common reason for people leaving the workforce. Okay, cognition and fatigue. Oftentimes there are multiple things that play into cognition. Certainly the medications we give you can affect your cognition, right? Fatigue can affect it, right? So I'm much brighter and better in the morning than I am in the evening after I run around with the kids and all that good stuff. And then sometimes mood changes can also affect your cognition. So ways that we address that. Neuropsychological testing can be done if needed. Sometimes we do cognitive rehabilitation, and then we certainly want to address the other causes, right? So I tell people oftentimes there's this much from the MS, right? And then if we add, let's say we're giving you a whole bunch of medicines that make you sleepy and kind of dopey, it becomes this big of a problem, right? And then what about if you're very tired or fatigued or that's not being addressed? It becomes this big of a problem when this much of it is from the MS, okay? So we have to make sure that we're addressing all of the other issues that may be playing into that symptom and not necessarily blaming all of it on the MS if it's not all due to the MS. Okay, and then employment, and we had just a great talk. Oh, she's gone. But we had a great talk about Social Security and disability. But certainly issues with employment can change over time, and that is often very fluid with MS because you could have a relapse and need to go on short-term disability and then improve and go back to work. Sometimes you need what we call intermittent FMLA, where if you have a bad day or a couple bad days, you have some leeway with your job, so you'll have some days off and your job will be protected. And then in some cases, we get to the point where we can't work and we need long-term disability. So there are all things that may be needed sometimes multiple times throughout the course of your MS. And so other things to think about or address are disclosing your diagnosis to employers. It certainly is an individual decision. I have some people who do that and it's very supportive. I have some people who do that and it doesn't work out very well for them. So that's an individual decision that you would need to make. Also, sometimes we need to do workplace accommodations. If you were working a job and had a relapse or symptoms, we sometimes have to write accommodations to work from home. Those are things that you would coordinate with your healthcare provider. And then in some cases, we do vocational rehab. If maybe you weren't able to do your previous job, but you may be able to do something, and we maybe don't need long-term disability, okay? So those are all things that change over time. Again, important to address those with your physician and your physician's office. All right, and mood changes. Certainly that is something that can change a lot over time too, especially when people you hit different bumps in the road. So certainly I tell people life is stressful. If you're awake, you're going to have stress. Okay. But certainly MS is an additional stress on top of that. And so a lot of the stress with MS has to do with the fear of the unknown. But a lot of it has to do when you encounter a bump in the road or you have a bad relapse, what does that mean for my future? So certainly some of the most common mood changes or mood issues we see with MS are depression and anxiety and bipolar disorder. We also see pseudobulbar affect or PBA, which is inappropriate laughing or crying. Again, those are certainly things to address with your physician. And ways that we can address that would be counseling in some cases, medicines if we need those, referral to psychiatry, and support groups. Okay. All right. And then finally, I think this is close to my last slide. It's important to also bring your listening ears, right? When you think about your care, you are part of a care team. Your team includes certainly yourself, your family members and the people that help you, but also your physician. So it's a teamwork, right? When you go to a physician, hopefully part of the reason that you go to them is because you feel that they have an expertise and you trust their knowledge and the fact that they've been studying and treating people on a regular basis. So it's important to recognize all information is not good information. Whatever plan you and your doctor decide on, you need to stick to that so that if you're having issues or problems, we know that it's because whatever we're doing is not working and not because you're not doing whatever we said we were going to do, if that makes sense. What works for everyone else may not necessarily work for you. Remember in the beginning we said it is not a one size fits all. And I have people that come in all the time and say, my auntie is taking blah, 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 blah. And my cousin called me and told me to take, fish eggs or whatever, and I'm like, I don't think that's a good idea, So recognize that what works for everyone else may not work for you, okay? And then teamwork with your physician and with your care team is extremely important. All right, last two slides. When I is replaced by we, even illness becomes wellness. And all I need is peace, love, and a freaking cure for multiple sclerosis. Thank you very much. Thank you guys so much for your attention.
So next up we have Dr. Ben Thrower, and I guess a lot of you do know Dr. Thrower. He's a neurologist and the medical director of Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia. He attended undergraduate college at Florida State University, boo, and medical school at the University of Florida. His neurology training was at the University of Texas Health Sciences Center in San Antonio. Dr. Thrower is the senior medical advisor for the MS Focus and co-authored Navigating Life with MS for the American Academy of Neurology. He has been the principal investigator on over 70 clinical trials studies in MS. He and his patrician wife, Karen, serve on the board of Comunidad Connect and provide medical care to the underserved areas in rural Nicaragua. They are part-time pirates, in case you haven't seen him like that, and avid Harley fans. So let's welcome Dr. Thrower.
Thank you guys very much. Dr. Williams, thank you so much. That was awesome. Thank you, thank you. She's a tough act to follow. So I'm going to try to segue off of what Dr. Williams was speaking about. So Dr. Williams was talking about the pieces of the puzzle. And so how do we put those pieces of the puzzle together, and what would that look like in real life? It really does take a village to do comprehensive MS care. Okay, here's my first thing. There. So what I'd like to do is put this into the form of a case study. So let's look at what some of the challenges might be for a person with MS, and how do we sort of use our pieces of the puzzle to kind of navigate through some of the challenges that this person is facing. So Mrs. Smith is a 39-year-old woman. She's a factory worker, factory safety engineer. She's had multiple sclerosis for 8 years. She's been on treatment for 6 years. About 2 years ago, she had a relapse that left her with some weakness on the right side. She's got some trouble walking. She has a foot drop. She's got some trouble with dexterity in her hand that makes it difficult for her to keyboard, to do fine movements in that hand. She's having some cognitive challenges. She's struggling a little bit at home and at work. In the workplace, that a lot of times the workplace is not static. Things change. We're asked to do more stuff. We're asked to do more with less. And so these are some of the challenges that she's struggling with. So how do we sort of deal with this? So we need to sort of think about what is comprehensive care and how does this work for her. So comprehensive care is, as Dr. Williams said, having all of the pieces of the puzzle to do what's right for the person with multiple sclerosis. There's a second part to that, though, and that's integrated care. Integrated care means that all of those pieces of the puzzle are speaking with each other. I can tell you of universities in the United States that have all of the pieces of the puzzle to do great multiple sclerosis care, and they don't do a very good job with it because those pieces of the puzzle are not talking to each other. So ideally, you're going to have both. You're going to have those pieces of the puzzle, and those pieces of the puzzle are speaking with each other. So one of the things, and Dr. Williams did a great job with this, is we've got to prioritize what is the problem list that we're working with for Mrs. Smith. The good news as we work through these things is that almost any symptom that you think of, we have a drug for it. The bad news is almost every symptom you have, we have a drug for it. We try not to do that. We don't want to turn you into a walking CVS or Walgreens. The National MS Society, the last survey that I saw, said that the average person with multiple sclerosis is on 6 medications just for their multiple sclerosis. Multiple sclerosis doesn't exist in isolation. People have other health problems, so they get on antihypertensive drugs, they get on medications for diabetes and hyperlipidemia. So we have to be very cognizant of not piling medicine upon medicine for the individual. So this is what her problem list would look like. So she's had some breakthrough MS changes. She had a relapse 2 years ago that has left her with a new level of functioning. She's having some weakness on the right side. She's having some mobility or walking issues. She's having some cognitive challenges, both at home and at work. She's got bladder symptoms. She feels like she's got to go. She better be there right away. Poor hand dexterity. And finally, some of these things are affecting her vocational ability. So this is a very busy slide. This is the village that Dr. Williams was mentioning. All of these healthcare providers, and we could add even more, may play a role in your comprehensive integrated MS management. So we have numerous types of physicians, physiatrists, neurologists, urologists that are playing a role. We have all of the therapists, the physical therapists, the occupational therapists, speech therapists. In the MS world, we rely on our mid-level providers, our nurse practitioners and our physician assistants to be a part of the team. That term now, so mid-level provider, we've been using that for a long time. Apparently it's not politically correct anymore. Now they're APPs, they're advanced practice providers, so they're apps. If you are in, bless you, if you are in a medical practice that is using nurse practitioners or physician assistants, one of the things that I've seen that is common sometimes with people that are new to working with that sort of provider, sometimes there's a reluctance to see that mid-level provider. It's like, no, I only want to see the doctor. You know, that Dr. Williams' nurse practitioner is not as good as Dr. Williams is. And that may or may not be true, but don't be afraid of seeing mid-level providers. These are highly trained individuals, and a lot of times they're bringing something very special to the picture. For us at Shepherd Center, if any of you ever worked with Tracy Walker, Tracy is an expert in bowel and bladder issues. She knows way more about those issues than most physicians will ever know. So again, these mid-level providers are an important part of this comprehensive integrated team. And it really does take a village, people. See what I did there, village people. How many people are too young to remember the village people? My wife's, oh good, I'll be back there. Yeah, my wife said, you're going to put up there the people under 40. You go, I don't remember the village people. So hopefully your village looks maybe not quite like that one. So let's go through some of the problems and solutions that from her priority list. So she had a breakthrough relapse that left her with a new level of functioning. So if the goal of these long-term MS therapies is no relapse, no progression, no new MRI lesions, at what point do we say we're not meeting that goal. No one has a perfect algorithm for saying when we need to pull the plug and go to a different treatment. But if you're not getting an A+ on your MS exam, if you've had a new lesion on MRI, if you've had a relapse, if you're having progression, we should at least be having that discussion. Can we do better? We have 16 FDA-approved treatment options now. Sometimes we do have other options, and maybe you would do better on another treatment. So who are the villagers that can help out with this? Well, the neurologists. You would have this discussion. You would go through some of the things that Dr. Williams talked about. How effective is a given therapy? How safe is it? How tolerable is it? What's going to be the best fit for that individual? Sometimes we need to get the case managers involved to help us with paperwork and to do prior authorizations. We as a team, the person with MS, their family, the healthcare team may say, we want to pick drug X. Your insurance company may say, well, we don't like drug X. We want you to try drug Y. How many of you are familiar with something called step edits? Step edits drive us crazy. Step edits means that the insurance company has decided that they want you to try drug X and Y before you get to try drug Z. And frequently there is no scientific or medical rationale behind why they want you to try these different therapies, and it just drives us crazy. So that is becoming more and more prevalent, and what one insurance company's step edit might be completely different from what another insurance company's step edit may be. So that's where our case managers can help out. Big thank you to our pharmaceutical companies who are here today supporting this program. They are part of the village, so they are the ones making these drugs, and then often they're the ones helping out with the copay assistance or the nurse training if we need to get someone out to train in an injectable medicine. Sometimes the programs they have to help with laboratory safety monitoring are really vital to that comprehensive integrated care. And then all of your different sources of information, the National MS Society, the MS Views, the MS Focus, and the MSAA can help. A lot of these groups have algorithms that we can use that will do sort of comparisons, unbiased comparisons of what are the risks and benefits of each of these different treatment options. So what about her mobility, her foot drop? This is one of my favorite things to talk about, our mobility issues in MS, because it's an area that I think we can sometimes improve people's quality of life so drastically. So she's got some balance issues. She's got some foot drop, especially with exertion. So who are the players that we might think about with helping out? Physical therapy is something we're going to think about. Wellness. It wasn't that many years ago that people with multiple sclerosis were told, do not exercise. We then went through a period where the thought changed to, okay, exercise is tolerated, but we still didn't think it was very important. We know now that it's a vital, very important part of that comprehensive integrated management of multiple sclerosis. And in exercise, we sometimes put that into the bigger category of wellness. People, again, with MS don't just have MS. People have other health conditions. And so we want to look at those comorbidities. Are we keeping people as healthy as they can be? Vocational rehabilitation. So maybe in her workplace as a safety engineer, maybe she has to walk a lot, and maybe we can somehow make some modifications to her workplace so that we make it a little bit easier for her. I saw a gentleman the other day who's a flight line safety engineer for an airline, and so he's supposed to walk out on the tarmac, but he has the option, if we just write a doctor's note, of him getting an electric golf cart and going around. So something like that could help him conserve his energy and let him still be in the workplace. Case management, again, for us at Shepherd, the case managers are so important because a lot of times they're sort of taking what we want to do in healthcare and making it a reality from a financial and an insurance standpoint. And then physiatrists, physical medicine and rehabilitation specialists. If you are really struggling with severe spasticity, for instance, these are the folks who might help coordinate something like a baclofen pump if we're going to go that route. These are some of the devices that we have out there for this lady's foot drop. So we have traditional ankle foot orthotics. We have some lighter weight devices called toe-off devices. And I will preface this by saying any of these sort of assistive devices, the real key is getting you in with a physical therapist and letting you try it out. What I might think is going to be a great thing for you just from looking at you in the exam room may not be a great thing at all until if you haven't tried it out. This is a really simple device, the Dorsey strap. You can go to that website, xstrap.com, costs about $40. If you were going, let's say that your foot drop only gives you trouble if you walk a really long distance, and you've got a trip to Disney World coming up, and you know with all that walking that foot's going to start dragging a little bit. Maybe something as simple as this. So this is just a soft insert, goes behind your heel. You have to have shoes with laces, and it's going to lace up over the top of your shoe. Doesn't give you any lateral support, but it'll get your toes up off the ground. Kind of another level up, the Sabo device. Has anybody seen one of these before? These are kind of a notch up from the Dorsey strap. That collar around your ankle is really, really sturdy. And those little cables coming down to your shoe are actually small steel cables. They are also very, very sturdy. This is a pretty tough device. Again, it doesn't give much lateral support, but it will get your toes up off the ground. And that dial on the top of the black cuff is actually a tension device. You can actually tighten up how much you want to raise your foot up with that device. That one's about $150 online. And again, no prescription needed. Even though you don't need prescriptions for those two devices, I would still encourage you to work with a physical therapist to really find out what's going to be the best for you. Then we've got the sort of high-tech devices, WalkAid and Binus. These are both transcutaneous peroneal nerve stimulators. They're going to make the foot work by stimulating the nerve on the outside of your knee. The WalkAid device looks like this. And then you've got the Binus device. Binus came out with an upper cuff that you'll see on the top part of the leg there that can actually stimulate either the knee flexors or the knee extensors. And then they just came out with the new, the L300 Go. This does not have the clip on your shoe. So the traditional Binus device has a little clip that goes on your shoe. I think you can see it down on the foot there. That's a radiotelemetry device, and it's sending a signal back up to the nerve stimulators and telling them when they need to fire. So now what they've got with the Go device is they actually, within the device itself, they can tell the nerve when to fire. The WalkAid device has similar, I would say a similar idea. It has built into it an accelerometer and tiltometer. Go back here for a second. So what the WalkAid device does is when your knee goes forward and accelerates, the device is going to fire. Not to pick on WalkAid, some of our folks do really well with this, but the weakness to the WalkAid device has been that the therapist has to set those parameters. They have to tell the WalkAid device, I want you to fire when this person's knee goes like that. Well, the problem in multiple sclerosis is that your knee may go like that in the morning, it may go like that in the afternoon, it may go like that in the evening. It changes throughout the day, and the WalkAid isn't always capable of adapting to those changes, whereas the new Go device is a little bit more dynamic, and hopefully we'll pick up on those changes. So our next problem is the cognition. As Dr. Williams said, we really think of cognition as being almost like part of a three-legged stool. The other two legs of the stool would be mood and energy levels. So what she's noticing is that she has some word-finding difficulty, Mrs. Smith does, and that sometimes she just feels like her short-term memory is just non-existent. She has a conversation, and a few minutes later she can't remember the conversation. She reads something, and by the time she gets to the bottom of the page, she can't remember what was at the top of the page. A lot of times people with MS who are describing these things, their brains almost look like a kid with attention deficit disorder. And when I hear that, I think of word finding and processing speed as being that small part of cognitive dysfunction that Dr. Williams described that is definitely MS related. When people start describing these really, really short-term memory problems, I start worrying about fatigue and mood, because what fatigue and depression will do is they will wreak havoc with your short-term, with your concentration in your short-term memory. If your concentration is affected, you're not storing new information. So what she's perceiving as a problem remembering what was at the top of the page may not really be a memory problem, it's a storage problem. She can't store that new information to recall it a few seconds later. The good news with that sort of problem is that's potentially treatable. If we address the fatigue, if we address the mood, her cognition may look a lot better. So the villagers that we're going to think about would be the neurologists, so we can hopefully help sort these things out. Cognitive rehabilitation through a speech therapist. So for our facility, It's the speech therapist that's going to do that cognitive rehabilitation. In other facilities, it might be an occupational therapist who's going to wear that hat. The neuropsychologist can do the formal neuropsychological testing. So if we really need to know what's going on in that individual, we do this standard battery of tests. Anyone ever had this? Yeah. It's not fun, is it? No. It's 6... Yeah, I always warn people before they go for neuropsych testing. It's like taking an examination that you didn't prepare for, and it's designed to push you to failure. Usually it's about 6 hours of pencil, paper, right brain, left brain, and you come out just feeling like you've been beat up. It's designed to push you to failure, but it gives us a lot of information in terms of what's working and what's not working. And then again, counselors, what if we think that some of this may be more mood related and the person is having a lot of stress issues? Well, other than medications for mood, maybe just helping a person through a counselor work through some of these issues might be part of that village. Bladder symptoms. So for Mrs. Smith, she's got the gotta go bladder. She feels like if she has to empty her bladder, she better be there right now. She feels like there's a gallon in her bladder. She goes and there's a very small amount. And 30 minutes later, it does this all over again. Maybe she gets to the bathroom on time. Maybe she doesn't. So this is how the bladder should work in the humans. The bladder fills up a little bit. It sends a signal to the spinal cord. The spinal cord says, hey, you should probably empty your bladder. Your brain steps in and says, well, that's very nice, but there's no bathroom nearby, and you're sitting in a meeting, so you're going to wait to empty your bladder until I say to empty it. So there's this sort of reflex mechanism with inhibition from the brain. Now, if you have MS lesions that come along and sort of mess with that pathway, you can end up with a couple of different types of bladder problems. Going back for a second. So the two people that we frequently think of as working with this would be the neurologist and the urologist. I always like to say, as neurologists, we deal with the brains, and as urologists, they deal with the drains. So that's the distinction. So, types of bladder dysfunction and multiple sclerosis. There are really three things that we can see. We can see an inability to empty. So this is someone who has a post-void residual. Post-void residual is how much is left in your bladder after you think you've emptied it. So if you go to the bathroom and you say my bladder's empty, but you have more than 100 cc's of urine in there, that's a problem with emptying your bladder. You can have something called bladder dyssynergia. So bladder dyssynergia means when that muscle on the top is squeezing, those valves on the bottom are not opening. So this is the, I've got to go, but I can't go. Maybe you turn on the faucet, maybe you think about a waterfall, and now the bladder relaxes and you can go. And then the third problem, that's probably the most common, is the inability to store. So this is the small overactive bladder. This is going to be a post-void residual of less than 100 cc's. So how do we know where you're at on that spectrum? One of the easiest tools that we use, and I'm going to skip over that one, that we use is called bladder scan. So in the past, if we want to know how much urine was in your bladder after you'd gone to the restroom, we would put a small catheter in, and that is still done. This to me is a lot kinder. So we have you go to the bathroom, the nurse just takes a quick picture under your belly button with ultrasound, and we can tell you how much is in your bladder. This is sort of the algorithm then that we would use based upon how much is in your bladder. One of the things we always want to have in the back of our mind is ruling out a bladder infection. If you come in with bladder symptoms, a lot of times we're going to get a sample just to make sure you don't have a low-level infection brewing, and then we're going to look at the PVR, and that's going to point us down one of those pathways. So if you have the small overactive bladder, we have a list of things we can do for that. We may have you limit fluid intake, but we're going to do that in very, very specific situations. One of the first reactions that people have if they've got to pee all the time is they say, well, I'm just going to drink less fluids. That's not a good treatment strategy in the long run. It's not healthy for your body. It's not healthy for your kidneys. And if you get concentrated urine in your bladder because you're chronically dehydrated, that's a bladder irritant. That concentrated urine, ironically, is going to make you have to pee more often because it's irritating the bladder. Bathroom breaks. Again, this is where maybe we could work with her employer, Mrs. Smith's employer, and say, you know what, she really's got to have access to the bathroom at least once an hour so that she's not torturing herself. Being able to get to the bathroom quickly. We have a whole host of medications called anticholinergic drugs. These are your Detrol, Ditropan type medicines. We have a new one now that's not an anticholinergic, the Myrbetriq, that may be helpful for some people. Other bladder irritants. So we talked about the concentrated urine as being a bladder irritant. Caffeine can be a bladder irritant, alcohol, and then aspartame or NutraSweet. So if you really want to irritate your bladder, have a rum and Diet Coke. You've hit the trifecta of bladder irritants. You've got your alcohol, your caffeine, and your aspartame all in one neat package. DDAVP is a kind of an old school treatment. Anybody familiar with DDAVP or desmopressin? So if you have to get up all through the night to go to the restroom and this urinary frequency and urgency is really disrupting your sleep, maybe we have you on one of those anticholinergic drugs. Maybe it's not doing quite enough. DDAVP at bedtime is another option. This can be a pill or a nasal spray. And what DDAVP does is it doesn't work on the bladder, it works on the kidneys. And it tells your kidneys to back off on urine production just through the night so that you don't have to get up quite as often. What do we do if you can't empty? So this is the analogy here would be this is a bladder. It's like you're pouring water in a glass and it's just overflowing, but it's never emptying. So for this, again, we want to make sure you have adequate fluid intake. We don't want you to be chronically dehydrated. We might have you go to the restroom on a regular basis, even if you don't feel like you have to go. We're trying to keep that bladder as empty as possible. Sometimes we have to think about intermittent self-catheterization. So if you cannot empty your bladder, we don't want that urine sitting in there all the time. The problems with urine being in the bladder chronically is it's a source for infections. It's a great place for bacteria to grow, and it's not healthy for your kidneys. That back pressure is reflected up to the kidneys, and you can actually damage the kidneys over time. We don't have as many medication options for managing this bladder symptom, but we do have some things like tamsulosin, which is Flomax. So we think of this as a medicine used in guys with a large prostate. Well, we can use it in both men and women who are having trouble emptying their bladder with multiple sclerosis. Sometimes the antispasticity drugs will help a little bit, and then still DDAVP just to get you through the nighttime hours. And then so her last sort of physical therapy, occupational therapy issue was the poor hand dexterity. So if she's having trouble with keyboarding, with fine movements, we can think about bringing in an occupational therapist. We might look at vocational rehabilitation or even a sort of an assistive technology department. Part of the therapy world is something called assistive technology. These are frequently IT type people, and they're going to set up keyboards to maybe have a different mouse movement, have bigger keyboards, things that can help get around some of those dexterity issues. One of the other issues we think about here is ruling out other sort of potential explanations. A lot of people with multiple sclerosis are prone to a little bit of carpal tunnel syndrome. A lot of our folks will say they wake up at night with a really numb hand and they just assume that it's part of their MS, when in fact what's happening is at bedtime, because of the increased muscle tone, is they're flexing their wrist down, they're pushing on the median nerve at the wrist, and they get a numb hand, and then that may persist all throughout the daytime. So sometimes we want to realize that there may be other explanations for her hand issues. And then with her vocational struggles, so again, she's feeling stressed out at work because of all of these things coming together. This is where we're going to bring in some, like a vocational rehabilitation person, maybe speech or occupational therapy to help her manage some of these symptoms. A disability attorney, like we had here this morning with Lisa. Case management can serve as that liaison with her employer. And then bringing her family on board also to kind of get the big picture of where are we headed here. I always tell our individuals that are looking at vocational changes is that frequently I, as a healthcare provider, can make the argument for vocational disability, but I realize that I may not have the whole picture. What I need to know with the help of all of these people and with the person with MS is, what does that look like for them? What am I doing to them financially if they go out on disability, and what am I doing to them psychologically if I pull them out on disability? A good friend of ours from when we first moved to Atlanta in 2001 has multiple sclerosis, and she was kind of a hotshot financial analyst person, and due to her MS, she went out on disability. And I would say it was a really big struggle for her psychologically for about 3 years because she was only in her late 30s. And her question was, now what? So I fought this fight for disability. I've got it. Now what? What do I do with my life? And so it took her a while to figure out, okay, here's where my purpose is at. So again, just because I can pull someone out on disability, I always want to look at the bigger picture and say, should I pull them out on disability? So finally, we're going to wrap up with the what if. So what about our contingency plan? So we're doing all of these other things. We've got her on a new treatment now. Hopefully that treatment's going to keep her from having any future relapses. But what if she did have a relapse breakthrough? How do we define relapses and what do we do about them? So we use a lot of different terms for relapse: attack, exacerbation, flare-up. They all mean the same thing, and we're comfortable with any of those terms. The strict medical definition is it's a new or worsened neurological symptom that comes on and lasts for at least 24 hours, and we don't have a better explanation for it. If you are having relapse-type symptoms, you're probably going to get questioned from whoever you're speaking with about things like infections. Do you have a UTI-type situation going on? We call those pseudo or false exacerbations because the underlying infection is driving it. The treatment for that is addressing the underlying cause. So with these pseudo relapses, the other thing that we think about is just symptom fluctuation. People with MS do have good days and bad days. Symptoms fluctuate. And then there are things that, just like heat exposure or sleep deprivation, that may sort of look relapsy, but if we address the underlying cause, you're going to feel better. One of the sort of underlying principles of relapse management is that whether we treat you or not, you're going to recover to the same degree. What the treatment's going to do is speed up your recovery. So let's say that you wake up one day and you have a numb little toe, and it doesn't affect your level of functioning, and we think it's a relapse, but it really isn't affecting you that drastically. Well, we do want to document it, but we may not decide to treat it. On the other hand, if you woke up with loss of vision in an eye, then we probably do want to do something to address that because people don't want to put up with that for a long period of time. We said that to strictly define it as a relapse, that the symptoms should be present for at least 24 hours. Well, we may not want to wait 24 hours, so don't ever feel like you've got to follow that rule. If you wake up one day and you are having trouble walking or you're having trouble with vision, don't wait 24 hours. Go ahead and call us and let your healthcare team know what's going on. So again, rule out infection, consider the risks and benefits of observations, and then even if we decide not to treat it, we still want to know about it because in the long run, that's going to factor into how effective we think your underlying treatment may be. This is your toolbox for working with relapses. Traditionally in the United States, we're going to think about doing 3 to 5 days of IV sodium medrol or methylprednisolone with or without a prednisone taper. Our Canadian colleagues have long thought that we're a little odd for doing IV steroids. They would take that IV steroid and convert it over into an oral prednisone. Or have you take that bottle of sodium medrol that normally we're going to run in IV, have you pop the lid off of it, pour it into orange juice, and just drink it. All three of those options really do the same thing. So if you're not thrilled about doing IV steroids or you don't have access to it or you have poor veins, one of these oral options may be an option as well. For a long time in the United States, we felt like the high-dose oral options may be associated with a higher risk of GI upset, but what research has shown is that the increased acid production that some people get with steroids is a systemic effect. It's not due to the local effect of the steroids, it's due to the steroids being in your body, and you're just as likely to get that whether we do it IV or by mouth. Medrol dose pack, so this is the little small dose of steroids. Probably not the most effective thing in the world. Do we use them sometimes? Yes. If you're having a big bad relapse and we really want to go after it, we probably need to do the higher doses of steroids. These are your steroid alternatives. So if you've tried steroids and they didn't work, or if you can't do steroids, we can think about ACTH. This is old school treatment that's come back around again. And there is some research to suggest that maybe ACTH which is the naturally occurring hormone that tells your body to make more steroids, that it may do things other than that as well. Our biggest challenge with ACTH is it's just really expensive right now, and sometimes by the time we get approval on it, the person's 4 weeks down the line and the relapse has done what it's going to do by the time we get insurance approval. IVIG or immune globulin, doing this for 5 days in a row can be a relapse management, and then for some very severe relapses, there is data out of Mayo Clinic from years ago showing that we can do plasma exchange for people who didn't respond to IV steroids, and they will, about 50% of people will respond to plasma exchange. This is almost like filtering your blood, if you will. It's a 2-week process done every other day. And I think that is it. That is our village at Shepherd Center, part of it anyway. So thank you guys very much.
Awesome, thank you. So we're going to ask Dr. Williams to come on up. We're going to give her a microphone. And we're going to ask Dr. Thrower to stay up there. Thank you, by the way.
Thank you.
That was awesome. All right, and I'm going to run around the room, and I need to see a show of hands first so I know how far I'm running. Who's got a question for either?
How long and how many steroid therapies can you have, like, let's say, within a year period?
Yeah, so good question. Nobody knows in an individual what the limit on steroids is. So the bad thing about steroid treatments is they can raise your blood pressure, they can raise your blood sugar, they can sort of lead to premature cataracts. So we don't know. I would say for me, and I'd love to hear what Dr. Williams has to say, I mean, probably 2 a year, 2 treatments a year. If you're requiring more than that, we should be having the why is your treatment not controlling your relapse discussion.
Absolutely, I would agree that there's not a specific number, but certainly if you're having or needing repeated steroids, then we need to address your disease-modifying therapy and what's going on there.
Okay, so I'm interested in knowing with the alternative alternative to with the steroids that you were mentioning, Dr. Thrower, are you going to be less likely to get diabetes on that alternative method?
Yeah, it's a good question. So IVIG and plasma exchange are not associated with any risk of raising your blood sugar. The ACTHAR, the ACTH, does in theory have the same risk because what you're telling your body to do is make more natural steroids. There's some data out there that would suggest that maybe that some side effects, like for instance bone density, there's a little bit of data suggesting that maybe bone density in some people with ACTH could actually go up. I think it's really not known. So I generally think of ACTH as carrying similar side effect risks to the steroids.
Yeah, I would agree. It's thought that the amount of steroids that your body produces with the ACTH is much smaller than what we give you if we give you IV steroids, but certainly I've had some people who've had significant side effects similar to what they have with steroids with the ACTH as well.
I was interested in the DDVPA. I don't know if I'm saying it correctly or not.
So do you use DDAVP?
No,
also?
not very much.
She's too young. That's right. See, DDAVP or desmopressin. So again, it's old school. So it's a naturally occurring hormone, and what it's doing is it's telling your kidneys to back off on urine production. A lot of times people are familiar with desmopressin or DDAVP in pediatric usage. It's used in kids. If you had, say, a 10-year-old boy who's having accidents and he can't go to sleepovers because he has bedwetting, well, you would give that boy either a nasal spray or a pill to get him through the night. Well, we can do that same thing in adults who are having frequent urination. The only real downside to the pill of DDAVP at bedtime is you have to watch the serum sodium. Sometimes people's sodium on DDAVP will drop a little bit, and it's only a bedtime medicine, not for daytime use. The thing that we also have to be aware of is a lot of individuals with MS are also on drugs like carbamazepine or Tegretol or oxcarbazepine, trileptal for things like trigeminal neuralgia. Those drugs can lower serum sodium also. So if you put someone on that and DDAVP, you've really got to watch their sodium.
Okay. However, all the stuff you just said, I have MS. I can't process all of that. So if you could just... Yeah,
break
it's like
it down.
Chinese. Yeah, Tell it
you
to me
could
like
take-
I'm a 2-year-old.
So you could take one pill of this DDAVP at bedtime, and what it may do is you may not have to get up and pee as often at night.
That's what I want.
There you go.
Okay, so how can I get that? Can you recommend, since I go to the Shepherd Center, can I go there and they can say, oh, here, Miss Davis, we're going to give you the DDAVP.
So just write it down when you come in next time. Say, hey, I was at Stewart's program on Saturday, and you guys talked about DDAVP. Tell me about it.
Thank you.
You're welcome. Thank you.
I wanted to ask you about stem cell research in the United States, if that is going on, and what is the state of that?
Okay, I'll start. So stem cell research has actually been going on for a long time, and it's been going on for probably 20, 30 years or more, mostly in Europe, certainly more recently in the United States. Some of the places, many of our larger academic centers, like Northwestern, USC out in California, maybe Mayo Clinic, some of those places are doing more stem cell research here in the United States. It still is considered experimental, right? It is not an approved therapy for MS. And, you know, the thing about stem cell research or stem cell transplant is that of the studies that we have, it seems like it can be effective. There's some research from Canada, I think a couple years ago, that suggested some people out to 10 years seem to do very well with stem cell research, stem cell transplant. But again, it is a very rigorous procedure, right? So oftentimes when people come to the office and say, hey, Dr. Williams, I want to go get that stem cell, like you don't just go get a stem cell transplant, right? It is a very similar procedure that's used for what we do for chemotherapy, right? So they have to wipe out part of your immune system, give you cells back. There's a long kind of process of recovering from that. So it is not something to be taken lightly. So the answer is yes, it is being done in the U.S. on an experimental basis in some of our larger research centers. You could likely, if you went out, find somebody who would do it. But certainly if my patients ask about it, I usually recommend they do it within some type of research setting where they can be monitored.
Yeah, so the autologous stem cell transplant, the bone marrow transplant, if you pick the right individual, and usually that means someone with pretty hot disease, it can be a very effective treatment, but the key is right individual. We've had 3 or more patients go to Mexico, to Clinical Ruiz. We've had several patients go to Russia. Buyer beware. I mean, this is not a walk in the park. This is real deal chemotherapy. The other type of stem cells that people get interested in are mesenchymal stem cells. These are the reparative stem cells, and that's, you know, when we think about the layer cake, you know, there's a 5th layer to Dr. Williams' cake, and we would love to be able to reverse the disability. Absolutely. And so we're getting there. A lot of the money that the National MS Society has spent has been on neural repair. So there are legitimate mesenchymal stem cell trials out there. There was one completed a couple of months ago up at the Tisch Center in New York. This is another case, though, where you've got legitimate research going on. Right. There are now over 200 for-profit stem cell clinics globally that will take your $15,000, $20,000, $25,000 and put something into your body. We don't know what they're putting into your body. Yeah. Dr. Fred Lublin is one of our mentors. He's a crusty old neurologist up in the Northeast, and he's famous for saying the plural of anecdote is not data. Just because 5 people went on Facebook and said that this worked for me, right. Number one, are they real individuals with MS? And number 2, it's hard. Right. We realize that people with different health conditions, whether it's MS, ALS, people get desperate, and it's frustrating that things move slower than we would like. So just be careful with the for-profit stem cell clinics that are out there. And
they usually do want that done yearly. Yeah, so usually it's 15 to 25 yearly for that procedure.
There was a great article in the AJC last Sunday about stem cells and sort of what's known and what's not known, and there was some reference to multiple sclerosis in there also.
I'm so glad you mentioned about the Facebook, because we have a lot of pages on Facebook, but you see the chatter going on with a lot of people talking about, oh, I went here, I went there, and they want us, MS Views and News, to talk about the good that they're getting from it. And I said, tell me in 6 months to 9 months from now how you really feel. Right now, what you're feeling is probably just placebo anyway. But again, we also tell people, you don't know who you're listening to on social media. We have no idea if that person had MS or even had it done anywhere. The Russians, yeah.
And we hope that the science will eventually catch up with some things, but it's important that if there's not really good science behind it, you have to question if people are willing to take this amount of money from people on a regular basis from something. I had one patient who did get it against my advice and was like, they basically told me, I don't know if it's going to do anything for you. I don't know if it's going to work, but give us $15,000 and we'll see.
But then the other option is, so you go see a doctor in Russia, and supposedly so many people have spoken about it. Now you come back to the States and you get sick. What do? Yeah. You guys can answer that.
Yeah, you don't get to, you're not going to call someone in Russia and say, but I think I got this, my immune system is still not normal, because they are using high-dose chemotherapy to wipe out your immune system. Even though the cells come back in numbers in about 28 days, they don't come back in terms of normal function for probably a year. And so if something bad happens, you could be in a world of hurt.
Great. Next question's here.
What is your general rule of thumb on treating relapses? I have struggled with this because I have very, very subtle, slow presentation. It's really only in retrospect that I can say, well, I had this for a few seconds on Wednesday, and then a couple days later it resurfaced, and then all of a sudden over maybe a 2-week period, it's clear that I have something going on. So with the steroids, do you want 24 hours, a week, 10 days? At what point do you say you're too far down the road?
So there's not a great answer to that. So generally if someone's like 4 months out from a relapse, then steroids probably wouldn't be that helpful. I think what I try to educate my patients about is, if you're having issues and they're lasting for a couple days, call us and let us know, right? So even if it's something subtle, then we can assess that and say, okay, do we need to do something or do we not need to do something about it? Because remember, all relapses people don't necessarily treat every single relapse if the symptoms are very subtle. But if you're having a change in function and it's lasting more than a couple days and you're not sick and you haven't been out sunbathing, then just give your doctor's office a call and let them know.
Next question.
Yes, this is about primary progressive MS. What's the latest information on the drug that came out and any other treatments that may be available? I can't take the one that's out now because of the cancer risk. So what's the latest? I'm doing the exercise and all those things and treating symptoms. Is there anything new?
So as far as I know, there isn't. So there are several drugs that are doing trials with primary progressive MS, but I do not know of anything that's on the horizon, like in the next year or two, that will likely be approved for primary progressive MS. And then certainly, we do have that one drug, Ocrevus, which was approved last year. But I don't know about your experience, Dr. Thor, but I have some patients. I've had a couple who have wanted to take it, but I have quite a few of my primary progressive MS patients who are like, well, I'm pretty stable. Let's just keep doing what we're doing.
Yeah, the Ocrevus is our only FDA-approved treatment for primary progressive MS. And I would back up at just something that you said about the cancer risk. And so I don't know that that's an absolute. So if you look, what caught people's attention with Ocrevus and brought up the cancer issue was really their breast cancer that they saw in the Rebif treated group. So it was Rebif versus Ocrevus. They saw 6 breast cancers in the Ocrevus group. They didn't see any in the Rebif group. But when you look at cancer risk across different drug trials, you have to step back and say, well, what would we expect to see in the general population? So for that group of women over that time period, what they actually predicted is that 11 people would have developed breast cancer just by natural history. So the fact that 6 did was a little lower. The really weird number that we can't explain is 0 in the Rebif group.
Exactly.
I would, I think it's not. So I think that would be something to discuss with your oncologist. I mean, the thing with oncologists is they're really familiar with how Ocrevus works. Rituximab is the sister medicine to Ocrevus. They have the same mechanism of action. Well, we stole rituximab from the oncologists. They had it before we had it. So they're very familiar with it. I would ask your oncologist, what is your comfort level with, given my cancer history, is this something that I could use? If so, what sort of monitoring do I need to do?
Absolutely.
Question.
Yes, all these options are great. I may be now poking the elephant in the room, and it's how are the health insurance companies, reacting to treating patients with MS with so many treatments and different treatment for everyone? Because it seems like, for the most part, they're trying to do a cookie-cutter treatment for MS, and everybody doing the same thing.
So that's a very interesting and frustrating question for those of us who practice MS. So each insurance company has a different formulary, and that formulary can change on. Oh, okay. That formulary can change. All right. Well, okay. I know. Everybody wake up. So that formulary can change on a yearly basis depending on what negotiations they make with different, pharmaceutical companies. So really, it's kind of a moving target. There are some insurance companies that are very open in terms of their formulary, where if we feel like someone needs to be on a certain drug, we can often write an appeal letter. But that is becoming increasingly difficult. They're becoming much more rigid, where they say you have to try this and have to try that. And often to us as medical providers, it doesn't make any clinical sense. It actually is kind of getting worse over time. So one of the things that I think people like the MS Society and groups like that are doing is trying to lobby to improve access to medications for people living with MS, because it really is a big issue right now.
It's very frustrating. So it used to be one of our bigger insurers here in Georgia is Blue Cross Blue Shield, and it used to be in the Atlanta metro area. We knew the local medical director, and we could call him up and say, hey, here's why we're thinking we need to go to drug X. That's largely gone now. So their contract now with Anthem, which is, I think it's in Wisconsin. You call this, you have no idea who you're talking to. Your local people, your local medical directors will say, it's out of my hands. I have no control over this any longer.
And oftentimes we're not talking to neurologists who are familiar with treatment of MS. So that kind of adds another layer of difficulty as well.
Thank you.
What are we treating fatigue with? What's the most sick, other than Nuvigil, Provigil? Is there anything else out there? Provigil raises my blood pressure. Nuvigil is good, but not the answer, if you will.
Yeah, so I always step back with fatigue and say, well, let's look at it as a big picture. What's your sleep like? So we know that 65-70% of people with MS have some underlying sleep disruption. Either it's getting up to go to the restroom frequently or sleep apnea, any number of things. Is the fatigue issue really a sleep issue, and can we intervene there? Are there other health problems? Does the person have thyroid problems? Are there medications that we're giving that are contributing to the fatigue? If you've dealt with all of that, and then it comes down to, okay, this is just MS-related fatigue, then our first things, we want to first focus on the wellness aspect. So with the wellness program, we've done some studies. When we put people into a 12-week exercise supervised program, one of the things that seemed to respond the best was fatigue. Energy levels got better. And it's a double-edged sword, because people are saying, you're telling me to exercise, and I just told you I'm tired. What part of this are you not hearing? We get it, and it's getting over that hump to get there. Medication-wise, I always think of kind of like a ladder. You've got an old-school supplement called acetylcarnitine, which was actually studied head-to-head with amantadine, and people with MS preferred the acetylcarnitine. It's over-the-counter, a gram a day, cheap and easy. Amantadine, old-school anti-influenza drug, works for 40-50% of people that take it. Then you get into the Nuvigils and Provigils. I personally think those can be the most effective things we've got. Our problem is the insurance coverage is almost non-existent now. It's just gone. And then we get into the stimulant drugs, so your Ritalins and Adderalls. We used to use a lot more of those before Provigil and Nuvigil were out. Now we're going back to them because Provigil and Nuvigil we can't get coverage for. Yeah.
Same here. I think, I always try to stress there's a part medicine plays and there's a part you play. And no medication will ever get rid of the part you play, whether that's eating right, or changing your diet, getting exercise, getting adequate sleep. There's always a part that you play in your health and wellness, and it's the same with fatigue.
I wanted to just mention I am on Nuvigil, and initially it cost me over $100 a month, and now it costs me $30 for a 3-month supply.
How are you doing
Sweet.
that?
Through my insurance. Insurance.
Yeah, so better.
Got good insurance.
That is, I wish I could say that was happening for a lot of
It's
people.
usually the other way.
Yeah.
Yeah, went from 100 to 400 for some folks.
Everybody familiar with GoodRx? Yeah, so it's an app on your phone. It price shops for your medications. Yeah, thanks for mentioning that.
Hers was less through foundation support.
What's
Hey,
that?
what about LDN? People talk about LDN for energy.
There's a lot of anecdotal research about LDN. There's a website about LDN that a lot of my patients go to. So it is a medication for narcotic withdrawal that some people feel helps with treatment of MS. I have had some of my patients who have tried it. If you look at the studies or the information on the website, the actual dosage that's recommended is a dosage that really has to be compounded. And the amount that we usually give that you can just get from the pharmacy is a little bit higher than what they recommend. So I've had some folks who've had it compounded. I've had some folks who have tried low-dose LDN. I haven't seen exciting results. I have maybe one person who felt like it really helped, but most people will take it for a couple of months. My stipulation is that I usually do not want them to take that alone as a disease-modifying therapy. And so most people kind of drop it after like a couple months or so.
Yeah, I'm with you on that. So I don't think I've ever seen any big side effects with LDN. And it's not terribly expensive, but at the end of the day, my experience has been kind of meh.
It doesn't hurt, but it doesn't help.
Yeah.
My question is this. I'm not trying to steer you all towards stem cell. You feel the way you feel based off of what you've already dealt with. What do you think would be the telling sign about stem cells? It seems very promising on one end. On another end, there are still problems to work out. Do you think time will be the telling sign?
So it depends on what stem cells you're talking about. So if you're talking about autologous or mesenchymal stem cell transplant, those have very, very promising results in terms of the research and in terms of helping MS. I think the danger becomes when we start talking about adipose or fat stem cells, which is a totally different ball game. And that's the type of stem cell transplant where people do a little bit of lipo and then they take some of those cells and then give them to you in your nose and your IV and your spine. So if you're talking about autologous stem cell transplant, which is traditionally used for like chemotherapy when people have cancer, or some forms of mesenchymal stem cell transplant, that has very promising results. I think that we do need more time to kind of get some type of algorithm for the procedure. There are also several studies that were looking at injecting the cells in different places. There was one in New York, they were looking at putting it in the spinal fluid. So I think we still have some kinks to work out, but I do think that will be a very good therapy for the appropriate patient with MS once, some type of algorithm or some type of standard procedure is determined.
And kind of underlying a lot of the talks about stem cells is this real desire to reverse disability. And so realize that stem cells are part of that discussion, but there are a lot of other research pathways that are being looked at. So we've got the studies on anti-LINGO, which is one of the potential neural repair agents. There's the cool stuff they're doing out at UC San Francisco where they're identifying molecules that are already FDA approved for something and seeing in a test tube if they repair damage. And the beauty of that is you skip the animal models, you skip the human safety trials, you go right into human safety testing. So stuff is moving, and it's not just on the stem cell front.
You stole my thunder. Anti-LINGO or other remyelinating medications. What is the update on it, and for whom will it be available?
So I was hopeful with the anti-LINGO trial that's going on right now that it would be geared towards people who are primary or secondary progressive or stable relapsing remitting, who are not having a lot of ups and downs, who you could really see the true improvement. Unfortunately, we were not in charge of setting the rules for that study, and what they're actually looking at are people who have had recent disease activity, either a relapse or new lesions on MRI. It's been really slow going getting people into that trial. We've at least looked at about 120 individuals to see if they might be candidates, and we've gotten 2 people into the study. So it is a multinational, large, trial. So, hopefully we're going to get some answers. Preliminarily, what we see with anti-lingo is it looks like it's very safe. It's 19 monthly infusions. It's our first. We're blinded. We don't know if our individuals are getting placebo or active treatment. In the other trials, they didn't see any big safety issues. The $1 million question is just, does it work? Yeah.
Although Dr. Leslie White is not doing kinesiology research anymore, she was definitely a bright voice on the horizon in regard to that as a complementary therapy and the significant improvement in symptom reduction and disease modification. And then I also wanted to ask you to talk about, in tandem with Dr. Leslie White's research for those 2 things, our Dr. Deborah Bacchus's research regarding the functional electrical stimulation bike.
Yeah, so Dr. Debbie Bacchus at Shepherd Center is our head of research, and one of her areas of a lot of interest is functional electrical stimulation bicycle. And so the idea with this is that putting people on an exercise bike, it could be a recumbent bike or sitting bike, and if they cannot move the pedals, we have sort of stimulators making the muscles work, stimulating those muscles, or having the motor actually help them move. There was some similar research in spinal cord injury with something called Locomat, which is a robotic treadmill. And the idea is what functional gains, what can we recover through these modalities? And so I think we are seeing recovery. So a functional electrical stimulation bicycle, people did have better endurance and better walking. Locomat and spinal cord injury, people had better endurance and better walking. The second question is, how are they improving? Is it through neural plasticity? Are we sort of rerouting around blockages from MS? Dr. Bacchus thinks that it may be more than that it may actually be changes in the muscles themselves. So as much as we know that MS is a brain and spinal cord disease, ultimately it does affect the muscles also downstream. And so she's doing some interesting research on how the muscles change with the functional electrical stimulation bike. I think the take-home message with all of this is that exercise is important. Everybody can exercise. People with MS are not fragile. We are not going to break you through exercise. You may hate us. We don't call them physical terrorists for nothing. But finding what you can do and working within those parameters, everybody can do something. I liked your analogy of you've got this much as an MS problem and this much. Well, the analogy I use is the bucket of disability. Some of your bucket is hardwired damage in the brain and spinal cord. Some of your bucket is deconditioning. And that deconditioning part of your bucket can be made smaller.
Yep, move it or lose it.
Yep.
What was that?
Move it or lose it.
Right. True.
She's
That's
looking
why you
at
see me
Stu.
running around.
Move it.
That's right.
Move it, Stu.
I'm moving it. I'm trying to lose it too.
Me too.
My question, and I know you can only be but so specific because it varies case by case, but Mom has been on Tecfidera for about almost a year now, and we are at a crossroads because we're at a disagreement whether she should try to start a different medicine or stay on Tecfidera. How long would you give a medication before you say, oh, maybe we should sit down and look at your options?
Right. So again, the things that we look at are we look at relapses, we look at tolerability, right? And we look at MRI changes. So when we talk about those medications working, those are the 3 things that we're looking at to see if something is working, right? Again, it would be ideal if we could see improvement, but that's not really our objective with the medications and the treatments that we have available right now. So usually I I try to give any treatment at least 6 months, right? So what we're doing is we're affecting the immune system. So that's not something that generally happens when you take one pill. So I usually give it 6 months, and we repeat an MRI somewhere between 6 months and the end of the first year. If there are changes, or if for one of those other reasons we feel like things are not working, then to me, that's how I practice. That's a general reasonable time, 6 months to a year. And if it's not working by then we look at our other options.
Any other questions out here? My gosh.
You guys are asking great questions.
Good questions.
It was good questions. It was great
Good thing
questions.
I changed my shoes. My other shoes had a time limit.
Well, if nobody's got any questions, then I've got a question. Well, firstly, let's thank these guys.
Thank you.
It took a lot of time from their day to be here today, and I want to thank you both.
Absolutely.
Thank you. I'd climb up there again, but my legs hurt.
That's
All
okay.
right?
You're doing great.
But did you all like hearing about something other than the MS medications? Okay, so that's very important because, we would like you to write that down too on these seminar evaluations. Let us know why you liked this kind of program and, what else you might want to see for the next time we come into town, all right? It's very important. How else are we going to be able to bring you or bring the collaborative what they need to know, all right? That's great. Thank you again. Prior to you leaving, I have to thank the company that gave us the sponsorship and the support to do today's program. This is called the Compass to Care. And so you saw the compass, all right? And we talked about different things. But the organization or the company that gave us the support to do this is Sanofi-Genzyme. I didn't get to say it at the beginning. I'd like you all to thank them, all right? So we can't do these kinds of programs without the pharmaceutical industry helping us to provide these programs. So again, thank you all for coming here today.